Thank you very much. I thank the organizers for actually asking me to talk about some of these emerging therapies for sickle cell disease. And Professor Okpara has spoken so much about the newer emerging therapies. So I will spend more time on talking about stem cell transplantation and automated red cell exchange. My name is Professor Bazuaye Nosa. I'm a professor of hematology and a stem cell transplantologist. I'm currently the Chief Medical Director of the Millennium University Teaching Hospital, Okada. As a way of content, I'll go quickly through these topics. My introduction, the distribution of stem cell therapy worldwide, the procedure briefly, condition regimen, and I would like to share data of the transplants we are currently doing in Nigeria. As a way of introduction, the first stem cell transplant was actually done in 1984 for sickle cell disease. And reports have shown that we have about 93% overall survival and 86% event-free survival with stem cell transplantation currently. Adult sickle cell transplant will require total body irradiation and a combination with alemtuzumab. Donor is a big problem, donor search. 14% of our patients usually have a matched sibling donor. The first cord blood was done in 1996. And then we've started now doing what is called Haploid, which is an alternative and as good as match unrelated donor. Technology has improved. We've talked about gene therapy recently by other speakers. And the first stem cell transplant in Nigeria was done in 2011 by Bazuaye et al. And this was published in the Annals of Transplantation in 2014. Now, this is the distribution of stem cell transplant centers worldwide. You can see that Nigeria has been represented since 2011. And the transplant procedure for stem cell transplant is as enumerated. You have to select our patients. We have to do pre-transplant preparation. We have to condition the patient by using condition regimen. We have to collect stem cells. We have to transplant these stem cells. And then there's also the immediate post-transplant supportive care. And then finally, you have to also do a long-term post-transplant care. For the selection of patients, HLA typing is very paramount. But the good news now is that our center with DKMS in Germany is currently running a free HLA typing for sickle cell disease patients and their families who will require stem cell transplantation. So we have an average of 3,000 free HLA typing for Nigerians yearly. For the condition regimen, there are several condition regimens, but we chose to use reduced intestinal conditioning because of less side effects. And we also now begin to do procedures with haploid transplants. Now, this is as simple as it is. Harvesting of stem cells, usually at both posterior superior iliac spines in the theater. At both heights, we collect stem cells. And then we go to transfuse these stem cells to the patient in the ward. And by the principle of homing, these stem cells actually get to the bone marrow and engraft. At the University of Benin Teaching Hospital, where we first did the first transplant, three transplants was done. We had to repeat one transplant, a total of 4, and we had a rejection in one of the transplants, and 2 were successful. And between 2014 and 2017, there was no transplant done in Nigeria because of the fact that the program in the teaching hospital couldn't continue. And in a private setting, in 2017, this is our first stem cell transplant patient in Nigeria. In 2017, we had actually started the collaboration with a private center. And then this is the protocol we used for the reduced intestinal conditioning for our patient using fludarabine with ATG and other combinations with respect to ATG, fludarabine, and busulfan. Now, for the haplo, which is a half match, this is the protocol, is a long protocol. From day -68, you start your conditioning with fludarabine and dexamethasone. And then until you get to day 0, and you do what is called the post-SI, day +3 and day +4 cyclophosphamide. Now, this is the characteristics of patients that were transplanted in a private center in collaboration with the stem cell transplant team in UBTH. From 2017 December to 2019, we've done a total of 9 transplants, and we had 1 rejection, 2 out of the 9 transplants were haploid transplants. We lost one of the patients who actually had a full engraftment, but went home and after about 6 months, came back with severe gastroenteritis, and then we lost that patient. That gave us another understanding that we need to keep our patients a little longer in the hospital. Now, this is our first successful transplant patient in the private center. This is the second. And then this patient, the first transplant patient in the private center was actually a donor with an AS. And that was our first transplant patient with AS. Also, this is the oldest transplant patient in Nigeria. He's a 19-year-old boy who was transplanted in February 2019. And this is the latest transplant we've done, the first successful haplo. She was done in August, about August 2019. And currently she is completely engrafted with a hemoglobin genotype of AS. I want to say that there are early complications from donors, recipients. Infection is a big problem, so we cover our patients with broad spectrum antibiotics. We also cover them with antifungal and antiviral. And this is to ensure that we cover our patients from infection. The complications also continues with respect to malaria, and tuberculosis is a very big problem, a very big challenge. So we give our patients prophylaxis of anti-malaria throughout the procedure. And they also have mantle tests before they commence transplants. I want to say in summary, the transplant activities in Nigeria from 2011 to 2019, we have a total of 12 transplants. We've done 10 of match-related donor, and then we've done a total of 2 which are haplo, and then overall survival, 11 out of 12 with 92% overall survival. And then mortality 1, overall disease-free, 75%. And a primary rejection, we had 2 primary rejections, although this patient also had high performance, high persistent fetal hemoglobin post-transplant, and also actually currently stable. Challenges in transplants in developing countries as enumerated: government insincerity, politics, funding, importation of drugs. Drugs are in dollars, and dollars are always going up. Personnel, training. We are currently doing a lot of training, both in apheresis and other part of stem cell transplantation. Inadequate power supply, insecurity, and then an attempt to copy foreign prototype has been a problem in establishing many transplant centers in Nigeria. And then the other modern therapies I want to also just highlight. People have mentioned hydroxyurea, but I also want to mention automated red cell exchange, which is currently being done in Nigeria. We're doing a lot of training of doctors, nurses in the act of automated red cell exchange. And then this is the 1-year report of a report from us in 2015 of our automated red cell exchange that we've done in Benin City. In conclusion, I would say that stem cell transplant is curative, especially for sickle cell disease, and with good supportive care, mortality could be reduced to as low as 10%. And many Africans could actually benefit from this cutting-edge medicine. And there is no need, there is also a great need for private collaboration as demonstrated. 3 transplants in the teaching hospital, 9 in a private setting within 2 years. And I think that will improve the stem cell transplant activities in Nigeria. I want to acknowledge the University of Benin Teaching Hospital, who sponsored my training in Switzerland, the Basel Hospital in Switzerland, Septec Healthcare Medical Center. I'm currently Benin Teaching Hospital, where we are trying to establish an international transplant center for Nigerians. I also want to appreciate my fellow consultants, doctors, and all other medical personnel. I thank you all for listening.